My topic is revision surgery for lateral approach. First of all, I would like to ask you, have you ever performed revision surgery for lateral approach? Show your hand. Okay, you are very lucky. So, nowadays, anterior approach or lateral approach to spinal column is becoming very popular. In Japan, we have a lot of cervical OPLL cases. More than 20% of total case we choose anterior approach, but sometimes it will fail because of non-union or something. For thoracic, we have a lot of deformity or trauma. Sometimes we need anterior approach to remove the vertebra. But nowadays, for lumbar, lateral approach is becoming very popular all over the world. This is today's my talk. First, I'd like to mention about surgical anterior revision surgery. This is 82 years old female. In Japan, now we are suffering of graying of society. We have a lot of elderly patients. So if you look at the lateral X-ray, the OPLL is K-line minus. This means a candidate for anterior approach. This CAT scan shows the double layer sign. This means dura is also ossified. In the situation, if you remove total OPLL, it's a high risk of CSF leakage. I use navigation and remove the vertebral body, but not complete. We say floating method, like this. You shouldn't remove the total OPLL. It's a high risk of dural injury. After that, you need posterior fixation. It's a MIS technique. Posterolateral approach. With a CM, we can put a pedicule screw from posterolateral approach. Most important thing is with a CM. Just 4 centimeter skin incision, we can put a pedicule screw. A lot. This is postoperative X-ray. Let's move on to thoracic case. Maybe you have a lot of this kind of case. So this is, again, 82 years old female. So T2, we perform BKP, but BKP was collapsed like this. So in the situation, what should you do? Posterior again or anterior corpectomy? We choose MIS anterior corpectomy with expandable cage. Now I'm using navigation. And nowadays, expandable cage is also navigated. Let me show you the video. Just 4 centimeter small skin incision, remove T10 rib, and then put the cage first, because for this case, at least 2 above 2 below fixation is necessary. After that, remove the 4 vertebra and then put the cage like this. This is pre-op X-ray, and this is post-operative CAT scan. Another case is 64 years of male, ankylosing spondylitis. As you know, for this kind of fixed kyphosis, we need 3-column osteotomy, usually PSO. We were planning to do PSO, but unintended open, it became unintended open osteotomy. Anterior part is open and become a complete 3-column osteotomy. For this case, we also perform mini corpectomy and multiple rod. For other spinal deformity, Dr. Ayush already mentioned a lot of complications, especially for PJK, proximal junctional failure. For revision surgery, you need this kind of big surgery. According to the paper, proximal junctional kyphosis, the incidence rate is from 20 to 40%. It's very high. My final is lumbar, lateral, and anterior approach. This is 40 years old female, L4, L3 birth fracture. For this case, we have a lot of very osteoporotic patients. Usually, you think about posterior fixation, but for this case, the patient has paraparesis. I choose anterior. The CAT scan is like this. Corpectomy with augmenting screw. This is CAT scan. So if you put 2 above, 2 below screw, the whole lumbar area is fused. This is not good idea for elderly patients. Anyway, maybe within 1 year, adjacent segment disease will occur. So this is another case, L5 collapse. The first, we perform simple laminectomy, but it doesn't work. So the collapse becomes worse and worse. We choose corpectomy. L5 corpectomy is very difficult because there is the vein, the ascending lumbar vein and iliolumbar vein. It's very difficult to approach. Let me show you the video. We always use navigation, not CR, even for this kind of severe condition. First, we are planning to make the skin incision, but just you look at this, 4 centimeter small skin incision. This is L5 vertebra. So now I decided oblique incision, like this. And then divide abdominal muscle, and then approach to the L5 collapsed vertebra. For this case, it can be helped 2 above, 2 below, but I usually use sacral iliac screw for this is very strong screw. Now I'm putting the cage and remove the vertebra with navigated osteotome. This is very useful. This one, you see? And then remove the collapsed vertebra completely, and then measure the sides. After that, you can put expandable cage. But unfortunately, the expansion cannot be navigated. We expand the cage and then take radiogram. We always get out of the OT and then take X-ray and then check the position. This is final X-ray. Another case is sometimes you put the cage too deep, so the cage protrudes the other side. What should you do? Of course, you have to remove the cage from contralateral side, but just small skin incision, like this. Another one, sometimes you put the cage into vertebra. In the session, you should put another cage, dual cage. Sometimes you cut ALL, you might think it's okay, but it's not okay. The rod will break in jail. Another one is, for this case, we would like to preserve the motion segment for this patient, but it was a mistake. PJF. So we did a revision surgery like this. 2004 already Bridwell reported you should extend to the fusion to sacrum. So take home message of my talk, spine specialists should master anterior spine surgery. Navigated expandable cage is very useful. For adult spinal deformity, T10 to SAI is a golden standard. Augmented screw is very effective for osteoporotic spine. Thank you for your attention.